My presentation is over prenatal testing, and I was the health equity intern. My presentation will also be focused on the health equity aspect of prenatal testing. Um, So I kind of organized here the order in which I will be presenting the points of my presentation. So we'll start with an intro to prenatal testing, then transition into prenatal testing types, then transition into discussing prenatal care and testing through a health equity lens, and finally we'll discuss some solutions and next steps for closing disparities within prenatal testing. So to begin, an intro to prenatal testing. First, I wanted to focus a bit on why I chose prenatal testing as my presentation and final project. So, as we know, the EB Foundation is a global healthcare advocacy organization established to provide resources and support to families impacted by Edwards syndrome, or also known as trisomy 18, and other rare diseases. Early intervention with prenatal testing can help prevent or mitigate the impact of certain genetic conditions that a baby may be prone to. Thus, an understanding of prenatal testing, including prenatal screening and diagnostic tests, is imperative. So prenatal testing, including screening and diagnostic tests, help provide valuable information about the baby's health. It is crucial to understand that prenatal tests are completely optional. Spreading awareness and educational resources on prenatal testing can help foster informed decisions, and it's crucial to consider disparities in the completion and offering of prenatal testing, especially when determining initiatives that promote health equity. So a quick overview on prenatal testing. Prenatal testing for fetal aneuploidy has been integral to obstetric care since the introduction of amniocentesis for diagnosis of Down syndrome in the 1970s. While testing choices have become more complex, a central tenet remains that pregnant women should be offered both screening and diagnostic testing with the understanding that these tests are completely optional and not required. So current prenatal testing cascades in the developed, primarily Western world consist of similar testing methods. First, a first trimester risk assessment for the most common aneuploidies, and a second trimester fetal ultrasound scan to identify fetal anomalies. In the case of positive risk assessment, invasive procedures such as amniocentesis or chorionic villus sampling are offered to allow diagnostic follow-up testing. And I pulled that from a resource of the study De Jong et al. So moving on to differentiating between prenatal screenings and prenatal diagnostic testings, understanding the clear difference between prenatal screenings and prenatal diagnostic testings is imperative and will lead to better informed decisions. According to the Mayo Clinic, prenatal screening tests can identify whether your baby is more or less likely to have certain birth defects, many of which are genetic disorders. These tests include blood tests, a specific type of ultrasound, and prenatal cell-free DNA screening. Prenatal screening tests are usually offered during the first or second trimester. Screening tests can't make a definitive diagnosis. If results indicate an increased risk for a genetic disorder, your health care provider will discuss your options for a diagnostic test to confirm the diagnosis. These are typically non-invasive procedures because they only require blood tests or specific ultrasounds. It's also important to know that an abnormal screening does not mean that the baby has a definitive health problem. However, if a screening test indicates a possible problem or the patient's age, family history, or medical history puts them at an increased risk of having a baby with a genetic problem, then that patient might consider an invasive prenatal diagnostic test. Diagnostic testing procedures are more invasive and may have a slight risk of miscarriage. Undergoing a prenatal diagnostic test is the only way to make a clear diagnosis for the baby. Again, it is completely optional to undergo prenatal testing. However, some tests are recommended for all women, including screenings for Down syndrome, gestational diabetes, or HIV, or others may be strongly recommended based on the birthing parent's age, personal or family medical history, ethnic background, or specific results of routine tests. So now transitioning to the types of prenatal testing, we will begin with common prenatal screenings. So to begin with ultrasounds are imaging tests that use sound waves to create a picture of how the baby is developing within the womb. So an ultrasound may be done to determine if there is a problem with the pregnancy, how far along the pregnancy is, or to take measurements and screen for potential problems. A pregnancy ultrasound may be done to do things like confirm a normal pregnancy, determine the baby's age, growth, or even sex, look for problems such as ectopic pregnancies or the chances of miscarriage, determine the baby's heart rate, look for multiple pregnancies such as twins or triplets, identify problems of the placenta, uterus, cervix, and ovaries, and to look for findings that might indicate an increased risk for genetic problems such as Down syndrome or trisomy 18. Moving on to cell-free DNA, which is also known as non-invasive prenatal testing or non-invasive prenatal screening, as shown by the abbreviations in parentheses there. Um, this screening analyzes small fragments of fetal DNA that circulate within the blood of the birthing parent. So during pregnancy, the mother's bloodstream contains a mix of cfDNA that comes from her cells and cells from the placenta. The placenta is tissue in the uterus that links the fetus and the mother's blood supply. These cells are shed into the mother's bloodstream throughout the pregnancy. The DNA in the placental cells are usually identical to the DNA of the fetus. Thus, analyzing cfDNA from the placenta provides an opportunity for early detection of certain genetic abnormalities without harming the fetus. This screen was first introduced in 2011 as a safe and reliable screening test to rule out common fetal aneuploidies in high-risk pregnant women, thereby reducing the number of invasive diagnostic tests. This screen is fundamental in helping look for chromosomal disorders that are caused by the presence of an extra or missing copy of a chromosome, including Down syndrome and trisomy 18. Moving on to maternal serum screening, this screen analyzes proteins in the blood of the birthing parent. So this test is optional and is usually offered between the weeks 15 and 22 of the pregnancy and help determine the risk of the baby being born with a genetic condition, including Down syndrome and trisomy 18, as mentioned. To determine the risk, estimate for the pregnancy, these protein measurements are combined with other information about the pregnancy, including how far along the patient is in the pregnancy, their weight, race, and diabetic status, and whether or not they are carrying twins or a single baby. Again, these screenings do not provide a yes or no answer about the presence or absence of these conditions. Rather, the screening identifies pregnancies that may be in a higher risk group, and in turn can serve as a guide to choosing further testing to confirm or rule out these conditions. Another important note is that these screens, although completely optional, should be offered to all women and not just pregnancies considered high risk. Moving on to common prenatal diagnostic tests, we'll begin with chorionic villus sampling, or abbreviated as CVS, which involves taking a sample of tissue from the placenta. So chorionic villus sampling is a test for pregnant women that checks the chorionic villi, which are tiny finger-like growths found in the placenta. Chorionic villi contain the same chromosomes as an unborn baby, so the CVS test can show if a baby has an extra chromosome or a missing or damaged chromosome. CVS testing is very accurate in making a diagnosis and can be done early in the pregnancy, typically between the 10th and 13th week. CVS testing is used to diagnose chromosome problems or other genetic diseases in an unborn baby, such as Down syndrome, trisomy 18, Tay-Sachs disease, sickle cell disease, and cystic fibrosis. Moving on to amniocentesis, this test involves the collection of a small amount of amniotic fluid from the sac around the baby, also known as the uterus. With this invasive diagnostic test, a medical provider would insert a long, thin needle through the belly and into the womb. A small amount of fluid, about 4 teaspoons or 20 milliliters, is removed from the sac surrounding the baby. In most cases, the baby is watched by ultrasound during the procedure. This screen is most often done between the 15 to 20 weeks of the pregnancy, but can be performed at any time between 15 to 40 weeks. Abnormal results would confirm a diagnosis and may mean that the baby has a gene or chromosomal problem, such as Down syndrome or trisomy 18, or birth defects that involve the spine or brain, such as spinal bifida. These diagnostic tests are usually offered to women who are at an increased risk of having a child with birth defects. This includes women who will be 35 or older when they are giving birth, had a screening test that shows that there may be a birth defect or other problem, have had babies with birth defects in other pregnancies, or have a family history of genetic disorders. As mentioned before, prenatal diagnostic tests are the only way in confirming a diagnosis for the baby and are more invasive procedures, meaning they also carry a slight risk of miscarriage. Now we will transition into analyzing prenatal care and testing through a health equity lens. So to begin, we will discuss women perceptions on access to prenatal care. And for this part of the presentation, I looked at a study conducted by Julia C. Philippi, who reviews women's perceptions on access to prenatal care within the United States. The goal here was to include all current literature directly surveying women on their experiences of access to prenatal care. Philippi did this by reviewing literature from 1990 to the present on women's perceptions of access to prenatal care within the United States. Literature within the United States. The Cint Hall and PubMed databases were searched using the keywords prenatal care, antenatal care, and access. Because of the differences in healthcare systems across countries, only research from the United States was included in this review. Articles were eliminated if they used data collected before 1985. Because the findings of the studies were consolidated, categories of barriers emerged, which we will get into later in the next slide. But for now, Philippi defines the aim of antenatal care as it having to do with assisting women in remaining healthy and aiding the health of the unborn. And antenatal care should also provide guidance to the birthing parent and their partner or family to help them in their transition to parenthood. Disparities in access to prenatal care and prenatal testing use prenatal care use contribute to the inequalities in health outcomes between ethnic, racial, and socioeconomic groups. Factors associated with late or inadequate prenatal use that were found in the study include a low education level, ages of less than 20 years old or older than 35 years old, the African race, with the CDC saying that African American women were 3.3 times more likely to die as a result of pregnancy complications than white women, and half of those deaths being preventable. Being of Hispanic ethnicity, or living in an area with few prenatal care providers. Julia C. Philippi reviews women's perceptions on access to prenatal care within the United States. And as mentioned, the goal was to include all current literature directly surveying women on their experiences of access to prenatal care. So as mentioned, the barriers were able to be consolidated. And we begin here by talking about the maternal barriers, which include poor motivation to begin care, unaware of pregnancy, hiding the pregnancy, plans to abort, depression, or belief that prenatal care is unnecessary, and fear of medical procedures. The maternal dimension of care encompasses aspects of the woman and her personal situation that affected her ability to obtain care. Despite barriers and fears, most women were motivated and able to obtain care at some point in their pregnancy. The most prevalent motivator for prenatal care was the health of the baby. Friends, family, and the father of the baby were mentioned as motivators, but with less frequency than the health of the baby. However, one study even listed the father of the baby as both a motivator and a barrier to care. Societal barriers are external roadblocks that create difficulty in access to prenatal care. Some of the most common societal barriers identified within the study include culture, finances, transportation, existing children and childcare, familial needs and desires, significant others' beliefs about pregnancy, and healthcare. The structural dimension encompasses the former of care and, to some extent, the provider of care. The cost of services and payment options are also cited as key barriers, especially for women who do not qualify for Medicaid. The language and cultural sensitivity of the clinic staff can also create barriers for women who are not part of the dominant culture of the area. Wait times for both the appointment and while at the clinic are mentioned in many studies as a barrier to care. One study of a middle-class women found that a 6-week wait time for the initial appointment suggesting that access problems exist even for privately insured women. To reiterate, the structural barriers are long wait times, location, hours of the clinic, language, attitude of the clinic staff, cost of services, and lack of child-friendly facilities. These barriers ultimately create medical barriers in terms of care given by medical providers. These include providers' inappropriate attitude, poor cultural sensitivity, language, or lack of a consistent provider. By the time that a woman sees a provider, she has overcome the majority of common barriers. Providers can act as a barrier through aspects such as the ones just listed. Motivators in the medical dimension include positive provider-client relationships and, to some extent, the health of the baby and the woman's health. Structural facilitators of care include clinic staff who were bilingual or could speak their language and were culturally sensitive, convenient clinic hours, and readily available public transportation. So I touched a little bit about relieving these barriers, but additional ways to relieve these barriers include changes in clinic policy and prenatal care format and the creation of child-friendly waiting and examination rooms as being possible solutions to help reduce these structural barriers. Additionally, maternal and societal barriers can be addressed through community education, and quality prenatal care can potentially reduce the rates of infant and maternal mortality and morbidity and reduce rates of long-term disability. Additionally, timing is important. Early prenatal care may help reduce rates of infant death and long-term disability through prenatal diagnosis of fetal anomalies. This study helped in further understanding the common perceptions that women have in regard to accessing prenatal care. This study also helped emphasize the fundamental principle of ensuring that all women have timely access to prenatal care and services, given that this is vital in helping decrease health disparities and improving maternal and infant outcomes within the United States. Moving on to variation and understanding of prenatal testing, the American College of Obstetricians and Gynecologists recommends that, quote, screening and invasive diagnostic testing for aneuploidy should be available to all women, regardless of maternal age, but it appears that this information is not being effectively provided to all women, and that many do not understand the messages conveyed. Thus, I analyzed the Bryant et al. Study, which conducted a randomized controlled trial in which a diverse group of 710 English and Spanish-speaking women of varying literacy levels and socio-demographic backgrounds were asked whether they had discussed prenatal genetic testing with their providers, whether they understood that the testing was optional, and whether they had undergone testing during their pregnancy. The ultimate goal of this study was to investigate women's understanding of prenatal testing options and of their own experience with screening, diagnostic genetic testing, or both. So, the key findings of the Bryant et al. Study. This study identified specific factors that limited women understanding on prenatal testing. The first involves racial and ethnic minorities. Racial and ethnic minorities and women of lower socioeconomic status are less likely to have a good understanding of prenatal testing options and of their own experience, according to Bryant et al. Latina women were less likely to say that they understood that the screening was optional, with 44.5% versus a 74.5% comparison with white women. Compared with white women, African American women and women whose race or ethnicity was considered as other, including Asians, Pacific Islanders, and Native Americans, were also less likely to have a clear understanding that diagnostic testing was optional. Additionally, women of lower literacy might be less likely to understand and recall screening conversations that occurred. Compared to women with adequate literacy, women with poor literacy were significantly less likely to recall having had a discussion about aneuploidy screening, with a comparison of 87.3% versus 93.7%. Finally, women receiving care in facilities primarily serving low-income women were less likely to know whether or not they had screening. 83.4% for low-income sites compared to a 93.8% for women in all other settings. This statistic may represent the clinic conducting a routine ordering of testing without women's knowledge or consent, or maybe assumptions made by the clinic that a particular patient would not want or need the screening, resulting in failure to facilitate such services. This makes a significant impact on the quality of care demonstrated by medical providers. Providers may be less inclined to conduct detailed discussions with patients they perceive as less able to engage. The study also found that providers being less likely to offer diagnostic testing to women under the age of 35, despite recommendations that diagnostic testing should be offered to women of all ages. Women aged 35 and older had greater than twice the odds of accurately reporting having been screened. Now we transition into perceptions by healthcare providers. Earlier, we discussed the common perceptions of pregnant women in regard to access to prenatal care. Now we will consider the barriers and facilitators of prenatal testing from the perception of healthcare providers. Heeman et al. Study conducted semi-structured interviews where 24 healthcare providers serving women in inner city neighborhoods with high rates of inadequate prenatal care were interviewed. The goal of this study was to elicit the experiential knowledge of prenatal care providers within the inner city of Winnipeg, Canada, regarding their perceptions of the barriers and facilitators to prenatal care for the clients they serve, and their suggestions on how prenatal care services might be improved to reduce disparities in utilization. So the barriers identified were divided into 4 categories, including caregiver qualities, healthcare system barriers, personal barriers, and program and service characteristics. In regard to the caregiver quality barriers, many providers spoke at length about qualities in themselves or other care providers that pose a barrier, with most participants conceding that providers' busyness or lack of time could be problematic for their clients. Providers also noted that negative personality characteristics in healthcare professionals sometimes presented a barrier to care. Rude or judgmental caregivers in particular were seen as the most problematic. In terms of healthcare system barriers, a lack of public awareness of prenatal care services frequently was noted as a factor in inadequate prenatal care. A number of obstetricians commented that sometimes women are unaware that they could access their services without a referral, while other healthcare providers voiced the concern that women simply do not know where to go for prenatal care or how to access certain services. A shortage of healthcare providers who offer prenatal care were also identified as contributing to poor access to prenatal care. In terms of personal barriers, healthcare providers discuss the fact that a number of women they see are dealing with personal barriers that may interfere with attending prenatal care appointments. The majority identified logistical difficulties related to transportation and childcare. Financial problems were identified as contributing to these logistical difficulties, with half of the participants specifying a lack of money for transportation as a factor in their client's decision not to attend prenatal care. Other providers commented on how women working in low-paying jobs were reluctant to take time off of work to attend prenatal care appointments. Healthcare providers also commented that they believe prenatal care was not a priority for some women because they were just simply not interested in prenatal care, or did not think they need it, or did not understand its importance. Women were also thought to avoid prenatal care because of a distrust of the healthcare system or due to personal pressures like addictions, intimate partner violence, or other socioeconomic issues. In terms of barriers regarding program and service characteristics, some healthcare providers noted that some services are simply too far away for patients. Visits are often too short, clinic hours may be inflexible or inconvenient, and the amount of time spent waiting in the office is just too long. High volume practices that resulted in rushed prenatal care appointments were also identified as an additional barrier. In terms of relieving some of the barriers, care providers discussed needing to provide culturally sensitive care as part of individualized care, which emphasizes the importance of making women feel respected and valued. Participants often identified the need for healthcare providers to educate patients with effective communication skills, including listening, showing interest, and being non-judgmental and accepting. In terms of a multidisciplinary approach to facilitating prenatal care, many providers spoke about their role in referring women to additional services or programs to supplement care or in receiving referrals from other services. To relieve barriers related to program or service characteristics, providers noted the importance of follow-ups and the appointment reminders. Several providers also noted the benefits of assisting women with transportation to attend the prenatal care visits, such as through the provision of bus tickets or taxi slips. Providers also emphasized the need to promote public awareness of where prenatal care services are located to improve access to care and reduce disparities in usage. Participants also offered specific ideas to assist with childcare, such as having additional space, play areas, supervised child minding on site, and home respite services. Finally, providers emphasized the need to make prenatal care more responsive to complex needs and shifting to community-based care supported by expanded midwifery services. So just to kind of close off this section then, I also analyzed disparities in genetic counseling. With this study, it aimed to evaluate disparities in prenatal genetic counseling by directly assessing if patients received counseling at the time of their prenatal visit. So this was done with the cross-sectional study, and nationally, 77.1% of women were offered counseling in the first trimester, were less than 30 years of age, of the white race, had a bachelor's degrees, or have private insurance. And those less likely to receive prenatal genetic counseling were minorities, specifically Black women. They were less than 25 years old, single, and presenting at a later gestational age. And then transitioning into socio-demographic disparities and decision making. Here, the goal of the study was to investigate women's preferred approach to prenatal genetic testing decision making and assess concordance between preference and experience. And then the results of that were that 5% of women preferred provider-driven decision making, 56% preferred autonomous decision making, and 39% preferred shared decision making, with only 57% of women experiencing their preference concordant decision making. And again, non-white women who were not college graduates and women who had lower literacy rates were less likely to experience their preferred decision-making approach. Specifically, Black women, Spanish-speaking Latinas, and women with less education were less likely to experience their preferred decision-making approach than white, more educated women. And then transitioning into solutions and next steps. Here, a study identified 8 key steps when developing a plan to reduce racial and ethnic disparities. For the purpose of the study, health disparities were defined as a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. And the 8 steps are listed on the screen. So an improvement in communication between patient and provider can avoid mismanagement, delays, or failure in diagnosis. Implementing new models that promote women's health across the life course in order to address our fragmented healthcare systems, implementing disparity dashboards, and perform enhanced maternal mortality and severe maternal morbidity reviews, ensuring equal standards of care for patients of all racial and ethnic groups, rallying key stakeholders, allowing for wide implementation of multidisciplinary initiatives, and a diverse cohort suggesting a list and description of each of the testing options offered, information about each condition being screened for, and a timeline for the testing and return of results, costs associated, and non-technical language. And so in aligning with that diverse cohort suggestion, I went ahead and created a learning resource along with my mentor, which further just elaborated on screening tests and the difference between screening tests, diagnostic tests, and the different types of them. And I even went ahead and translated it into Spanish. Um, just as one of the many interventions that can be made outside of the clinical space to help empower and educate women and their families. This ultimately helps in making informed choices and benefits those who might otherwise fall through the cracks of a busy, overburdened healthcare system. And I just want to give a special thanks and shout out to Sarita for this amazing opportunity and for my mentor, Cheyenne Walmsley, for helping me conduct this research and just putting this presentation together. These are my sources, and thank you so much. And I'm so sorry for going over time.